ఇదేనా స్టార్ట్ అయిందా చూడండి. స్టార్ట్ అయినట్టే కదా. ఓకే. So good morning everyone. So today we are going to talk about calcium metabolism and hypo and hypercalcemia. So calcium is one of the most abundant mineral in our body. So our human body contains 1 to 2 kilograms of calcium, out of which 99% of the calcium, total calcium, resides in the bone and 1% in the extracellular fluid, that is blood. So bone acts as a major reservoir of the calcium. So calcium is a cation which has a role in various metabolic functions of the body. That is it acts as a coenzyme, it acts as a cofactor, it has a role in skeletal muscle contraction, cardiac muscle contraction, it has a role in membrane repolarization, stabilization of the cell membrane. It has a role, it acts as a factor in coagulation, hemostasis. So calcium is one of the most abundant element in the human body. So it plays a vital role in various physiological and biochemical processes of the cells, such as cofactor in enzymes, contraction of muscles, and as a neurotransmitter. As I told earlier, total body calcium content is 1 to 2 kg, and 99% of it resides in the bones. So bone calcium serves as a reservoir to maintain extracellular calcium concentration. So normally 250 to 500 milligrams of calcium fluxes into and out of the bone daily, mediated by coupled osteoblastic and osteoclastic activity. So basically osteoblasts, when they are active, they result in bone formation, deposition of calcium. Osteoclasts are nothing but giant cells, precursors of macrophages present in the bone, which when activated cause bone resorption and result in increase in blood calcium levels. So as 99% of the calcium resides in the bone, most of the calcium metabolism or calcium hemostasis occurs by activity of osteoblast and osteoclastic activity, and 0.5 to 1% of the skeletal calcium is freely exchangeable with that of ECF. So one thing you have to remember is the blood calcium which we measure, that is blood calcium, normal level is 9 to 11 milligrams per deciliter. So any ion which is in the blood, it will be in both bound and free form. So bound form, which is bound to various plasma proteins, they are metabolically inactive, and free calcium, which is ionized free calcium, which is present in the blood, they are metabolically active. So the ionized calcium which is present in the blood is responsible for various functions of the calcium ion. So in blood, 50 out of the 9 to 11 milligram per deciliter plasma proteins, that is albumin, and 40% they are free ionized calcium, unbound calcium, which is metabolically active, and 10% of the calcium being a cation, it binds with anions in the body like bicarbonate, lactate, citrate, phosphate. They bind with the anions of the body. Being calcium being a cation, they bind with anions and form complex precipitates. So this constitutes about 10% of the total body calcium. So in a nutshell, total serum calcium is 9 to 11 milligram per deciliter, out of which 50% is free, metabolically active, 40% is bound to plasma protein, mostly albumin, and 10% are complex calcium, that is they are bound to anions like one minute, Nitesh. And 10% of the calcium is complex with anions like bicarbonate, phosphate, and citrate. So bound calcium is 40%, complex calcium 10%. So all three forms of calcium remain in equilibrium with each other. So for example, for better understanding, for example, in cases when there is hyperproteinemia, that is low serum albumin, so total calcium will decrease. The most bound because when albumin is decreased, obviously the bound calcium will decrease, as well as the ionized free calcium will also decrease. So maintaining the hemostasis, calcium hemostasis. So all the three forms of calcium remain in equilibrium with each other. So whenever there is hypoalbuminemia, bound calcium will decrease as well as ionized calcium will decrease. So the resultant net metabolic active calcium is same as in case of normal protein concentration. This is very important to understand. So calcium metabolism occurs with the help of three hormones and three organs in the body. So that is vitamin D, parathyroid, and calcitonin. And it is also affected by growth hormone, glucocorticoids, estrogen, testosterone, and thyroid hormone. So major three hormones are vitamin D, parathyroid, and calcitonin. And three organs which are taking part in calcium metabolism are bone, kidney, and intestine. So vitamin D is one of the important hormone in calcium metabolism. So vitamin D, the active form vitamin D is 125 dihydroxycholecalciferol. So 25 vitamin D, when the inactive form vitamin D, it is 25 hydroxylated in liver, and in kidney with the help of 1 alpha hydroxylase it forms the active metabolite of vitamin D, that is 125 dihydroxycholecalciferol, which is active form vitamin D. So basically vitamin D being a steroid hormone, it binds to the nuclear vitamin D receptors. So vitamin D acts on intestine and and bone, and it influences calcium metabolism. In intestine, the calcium is mainly absorbed in proximal small bowel, that is duodenum and jejunum. Duodenum and proximal jejunum. So the vitamin D receptor present in the small bowel, when they are stimulated, they increase the expression of TRPV5 and TRPV6, which are luminal receptors for calcium. So once they are stimulated, the TRPV5 and TRPV6 receptors, which are present in the lumen of the small bowel, they absorb calcium. So once they are absorbed, this calcium has to be transported along the cell through the extracellular space. So this action, it is done by calvendin 9K protein, which is also under the influence of vitamin D. So vitamin receptors are also expressed on the bone cells, that is osteoblast cells. So the osteoblast cells, when they are stimulated by vitamin D, they increases the synthesis of extra bone matrix proteins, that is osteocalcin, osteopontin, and type 1 collagen. So the net is increased calcium. Net effect is increased calcium deposition and synthesis of extracellular matrix proteins, that is osteopontin, osteocalcin, and type 1 collagen. So vitamin D and parathyroid, when both they are given simultaneously, they induce the rank ligand, which promotes osteoclast differentiation and increases bone resorptions. So vitamin D receptors are also present on parathyroid glands. So when there is excess vitamin D, basically vitamin D and parathyroid are antagonistic. So when excess vitamin D is present, the parathyroid hormone synthesis is decreased. So conversely, when there is low vitamin D, there will be increased proliferation of parathyroid glands and parathyroid hyperplasia and hypoparathyroidism. So the actions of vitamin D and synthesis of parathyroid are antagonistic to each other. So vitamin D in liver, there is 25 hydroxylase enzyme, which will result in 25 hydroxy vitamin D. This 25 hydroxy vitamin D is still inactive. This is activated in kidneys with the help of 1 alpha hydroxylase enzyme. So this activated vitamin D, that is 125 dihydroxycholecalciferol. This is the active form vitamin D. So they are basically synthesized in kidney. So this hormone actions on bone. It will stimulate the vitamin D receptor on osteoblast cells in the bone. So vitamin D receptors, once when stimulated on the osteoblast cells, it will cause increased deposition of calcium, increased synthesis of bone marrow extracellular proteins, that is osteopontin, osteocalcin, and type 1 collagen. So net result is bone formation. And vitamin D on intestine. So one thing what we have to know is calcium is absorbed in both ways. One is passive transport, one is active transport. So active transport is dependent on vitamin D. Passive transport passive transport, it occurs by a passive diffusion of calcium through enterocyte membrane. So once the vitamin D, once it's absorbed in the blood, they cause increased expression of TRPV5 and TRPV6 receptors on the luminal surface of the small intestine. The luminal surface, receptors, they absorb vitamin D, and the vitamin D is transferred across the cell via calmandin 9K protein. So the resultant net absorbed vitamin D reaches the blood and it is absorbed systemically. So net effect of vitamin D on intestine is net calcium absorption, calcium phosphate absorption. So resultant, it will increase the blood calcium. So vitamin D is also causes negative feedback of parathyroid hormone synthesis. So whenever there is excess vitamin D, there will be decrease in the of parathormone, and decrease in vitamin D causes parathyroid hyperplasia. So one is vitamin D we have completed just now, and we have to see about parathyroid hormone effect of parathyroid hormone on calcium metabolism. So parathyroid is a 84 amino acid peptide single chain peptide secreted from parathyroid glands. So parathyroid hormone acts on the GPCR G protein coupled receptor subfamily of receptors. In kidney, it reduces the excretion of calcium. That is, it acts by various mechanisms. One, parathyroid stimulates 1-alpha hydroxylation of vitamin D, cholecalciferol. So net effect is active vitamin D formation. It also stimulates calcium exchange in distal convoluted tubule. So in distal convoluted tubule membrane, there will be a sodium calcium exchanger, that is ATPase dependent. So parathyroid causes activation of this pump and net calcium absorption. So on bone, parathyroid has various actions on bone. So when intermittent, but the chronic effects of parathyroid are to increase the number of both osteoclast and osteoblast cells to increase the bone remodeling. The basic effect of parathyroid is bone remodeling. So in normal physiological conditions, it increases both osteoclast and osteoblast to increase the bone remodeling. So if we administer parathyroid in intermittent doses, that is 1 to 2 hours a day, it will cause net bone formation. So this phenomenon, this principle is basically applied in patients having severe osteoporosis. In severe osteoporosis, there will be decreased bone density because of loss of calcium and other bone marrow extracellular proteins. So in such patients, we administer parathyroid or its analogs 1 to 2 hours a day. So net effect is bone formation rather than bone resorption. So continuous exposure to elevated parathyroid levels lead to widespread osteoclast mediated bone resorption. So for example, in case of parathyroid adenoma, there will be excess release of parathyroid. So this continuous exposure to elevated parathyroid levels in the blood will lead to osteoclast mediated bone resorption. So in a nutshell, what we have to see is parathyroid in physiological doses causes bone remodeling. Parathyroid, if it is administered in pulses, that is 1 to 2 hours in pulses, that is 1 to 2 hours a day, it will cause bone formation and bone formation. If there is continuous exposure to parathyroid levels, it will cause net bone resorption. So it acts indirectly on small intestine. That is, basically it acts on kidney to produce 1-alpha hydroxylase, which will lead to the formation of active metabolite of vitamin D. This active metabolite of vitamin D increases calcium reabsorption from the small intestine. So indirectly, parathyroid potentiates the calcium reabsorption from the small intestine. Parathyroid acts on kidney, that is distal convoluted tubule, to increase calcium reabsorption. So calcitonin, it is secreted from paraphyletic cells of thyroid gland. Action of calcitonin and calcium is antagonist that of parathyroid. So calcitonin promotes calcification by increasing the activity of osteoblasts. Calcitonin decreases bone resorption and increases the excretion of calcium in urine. So basically, calcitonin promotes calcification by increasing the number of osteoblasts. So it is antagonist that of parathyroid hormone. So the serum protein, as I told earlier, serum proteins basically 40% of the calcium it is bound to albumin. So in case of albumin deficiency, that is hypoalbuminemia, total calcium is decreased, but ionized calcium is normal, and there will be no net deficiency. There will be no deficiency manifestations, because the ionized calcium and bound calcium are always in equilibrium. So once the unbound calcium is once the bound calcium is decreased, the free calcium will also be decreased. So there will be net balance of ionized calcium and and bound calcium. So ionized calcium is metabolically active. The one thing what you have to remember is whenever there is deficiency of albumin, so net calcium binding will be decreased. So body will compensate by decreasing the ionized calcium also. So there will be no deficiency manifestations. So one thing is in alkalosis favors the binding of calcium with proteins. So net consequence is lowering of ionized calcium. Acidosis favors ionization of calcium. That is, whenever there is alkalosis, the unbound calcium will bind to proteins, and there will be net lowering of ionized calcium. So normal dietary intake of calcium is 400 to 1500 milligrams per day. So as I told earlier, intestinal absorption occurs both by active and passive mechanisms. So passive accounts for 5% of daily calcium intake. So active transport. So basically, the dietary intake of calcium is 400 to 1500 milligrams per day, out of which 5% is by passive absorption. So active transport, which is dependent on vitamin D. Vitamin D, that is, vitamin D induces TRPV5 and TRPV receptors in the small intestine, and the calcium is absorbed. So most of the calcium is absorbed in proximal small bowel, that is duodenum and proximal jejunum. So optimal rates of calcium absorption requires gastric acid. So one thing you have to remember is whenever there is high levels of vitamin D in the blood, there will be increased calcium absorption. So once the so at high levels of calcium intake, synthesis of vitamin D is reduced and decreased absorption of calcium. Opposite occurs with dietary calcium restriction. So whenever there is decrease in dietary calcium, the increase synthesis of vitamin D and increase in dietary absorption of calcium. So out of the total dietary intake, 100 to 200 milligrams per day is excluded as obligate component of intestinal secretions. So from the kidney, 8 to 10 grams of calcium per day is filtered by glomeruli, out of which only 22 to 3% appears in the urine. So 97% of the calcium is absorbed. So 65% of the filtered calcium is absorbed in the proximal columnar tubule because of passive. It is because of passive transport. In proximal columnar tubule, one thing what you have to remember is most of the nutrients, most of the minerals, almost 60 to 70% of the nutrients, minerals, and everything which is filtered in the glomeruli are reabsorbed. Calcium also is getting absorbed along with other nutrients, other minerals in the proximal columnar tubule, that is 65%. So 20% of filtered calcium is absorbed via thick cortical ascending limb of loop of Henle. So basically, the glomerulus, descending limb, ascending limb we have, and loop of Henle. In loop of Henle we have descending limb, ascending limb. So in ascending limb we have thick segment. In the thick segment of ascending limb, 20 Henle is independent of parathermon and vitamin D. So parathermon basically acts on distal columnar tubule, via distal columnar tubule to cause increased calcium absorption. So 10% of the filtered calcium, the 60% is absorbed in proximal tubule, 20% absorbed in loop of Henle, and 10% of the calcium is absorbed in distal columnar tubule. So this 10% which is absorbed in distal columnar tubule is dependent on parathermon hormone action. So basically, parathyroid hormone causes increased expression of TRPV5 receptors on the luminal surface, and activation of sodium and calcium exchanger. The net effect is calcium absorption. So as I told earlier, it moves up. Once the TRPV5 receptors are activated, the calcium has to move across the cell membrane. So this is done by calvinin protein, which is under influence of parathyroid hormone, and the calcium and sodium ATPase enzyme, that is a pump which is present in the basolateral membrane. This causes net calcium absorption. So in a nutshell, 65% of the calcium is absorbed passively in proximal columnar tubule, 20% absorbed in loop of Henle. This loop mechanism in proximal tubule and loop of Henle is independent of the hormones, and the 10% which is absorbed in distal columnar tubule is dependent upon parathyroid hormone. So this is thick ascending limb of loop of Henle. As I told earlier, this is calcium sensing receptor present on the basolateral surface. Once there is hypocalcemia, this receptor is getting activated, and this activated receptor will cause net absorption of calcium and magnesium through paracellular pathway. That is paracellular. This is a paracellular 1 protein. This protein causes net absorption of calcium and magnesium. So normally there is sodium, potassium, chlorine pump in the luminal surface, which will cause net absorption of sodium and potassium. This is active normally. So once there is hypocalcemia, this receptor is activated, and they will cause net absorption of calcium and magnesium through paracellular pathway. So this is distal convoluted tubule. The mechanism here is dependent upon parathyroid hormone. And earlier here in the loop of Henle, it is independent of the hormone. So a distal convoluted tubule, whenever there is hypocalcemia, so the parathyroid hormone stimulates the TRPV5 receptor, which will cause absorption of calcium. This calcium, once in the tubular cell, this has to be transported to the basolateral surface. So this transportation occurs by binding to calmandin protein. So once it is towards the basolateral surface, the sodium and calcium exchanger pump, which is here, this will get active, and it causes absorption of calcium and release of sodium into the intercellular uh, intercellular in the distal convoluted tubule. And also one more thing, there is one more pump called calcium ATPase. So net calcium absorption occurs by calcium sodium exchanger and calcium ATPase pump. So this is daily requirement of calcium. So in the summary of the discussion, calcium is a major hormone, major mineral in our body. Total body calcium is 1 to 2 kilograms. 99% of the calcium resides in the bone. So bone acts as a reservoir. So majorly three hormones are important. That is vitamin D, parathormone, and calcitonin for maintenance of calcium metabolism. And three hormones are involved. That is kidney, intestine, and bone. So actions of vitamin D. The active form of vitamin D is 125 dihydroxycholecalciferol. It acts on intestine to cause net calcium absorption. It acts on bone to cause to cause increased bone formation and deposition of extracellular matrix proteins. So net there will be increased serum calcium, vitamin D. Vitamin D will cause increased serum calcium and increased bone formation. Whereas in parathormone, secreted by parathyroid glands, it will cause net calcium absorption from the kidneys. Indirectly, it will cause calcium reabsorption from the intestine by activating vitamin D. So parathormone in physiological conditions will cause bone remodeling. Parathormone in excess parathormone continuous exposure to excess parathormone will cause bone resorption by activating osteoclast. Whereas pulse therapy of parathormone will cause net bone formation. So these are three main important functions of parathormone. That is one, physiological levels it will cause bone remodeling. In therapeutic level, in pathological levels, that is increased serum parathormone continuously will cause bone resorption. If parathormone, if given in pulses, that is 1 to 2 hours a day, will cause net bone formation. So calcitonin is another enzyme secreted by parafollicular cells of parathyroid gland. The net effect is calcium. Net effect is bone formation. Just a minute. Sir, our patient, sir, the nurse sir is getting discharged, sir. We want discharge. Sir, the patient is right now conscious, sir. There is no alcohol withdrawal. He is oriented. Sir, the discharge advice I am advising aluminum for 10 days, sir. Now 4 days over, sir. Yes, sir. Yes, sir. Yes, sir. I will see. Yes, sir. Yes, sir. Okay, sir. Okay, sir. Yes, sir. I will see, sir. Okay, sir. Okay, sir. Okay, sir. Okay, thank you. Okay. So these are daily requirements of calcium. Adults will require 500 milligrams per day. Children will require 200 milligrams per day. And pregnancy and lactation will require 1500 milligrams per day. So biochemical functions I have told earlier, it is a major constant in bone metabolism, contraction, excitation and contraction of cardiac muscle, skeletal muscle, decreased neuromuscular irritability, transmission as a it is required in neuromuscular transmission. As I told earlier, calcium is an important factor in blood coagulation. So hypocalcemia. So patients can be basically normal level of calcium is 9 to 11 milligram per deciliter, out of which 40% is bound to albumin, 10% is complex calcium, and 50% is ionized calcium. So decrease in ionized calcium will cause symptoms of hypocalcemia because ionized calcium is metabolically active. So patients can be asymptomatic if the decrease in calcium is mild and chronic. So in mild and chronic hypocalcemic cases, patients are mostly asymptomatic. If there is acute decrease in ionized calcium, the patient might be symptomatic. So the most common symptoms of hypocalcemia are paresthesias of fingers, toes, and circumoral paresthesia, because calcium is required for normal neuromuscular stability. Once there is hypocalcemia, there will be neuromuscular irritability. So this irritability will cause excessive firing of neurons and increased paresthesia, that is of fingers, toes, circumoral region. So clinically we see by Chauster's sign. Chauster's is nothing but once you tap over the facial nerve near the tragus of the ear, there will be facial twitchings because of contraction of the muscles supplied to the facial nerve. This is because of nerve irritability seen in hypocalcemia. So once again I'll repeat, in Chauster's sign, once you tap the facial nerve near the tragus of the ear, so after the resultant action is there will be increased twitchings of the muscles supplied with the facial nerve because the nerve is irritable. One is Strauss's sign, nothing but once you inflate the BP cuff above the systolic blood pressure, there will be a spasm, carpopedal spasm. So other one thing is there will be prolongation of QT interval also in ECG. And in severe cases, there will be seizures, carpopedal spasm, laryngospasm, bronchospasm, and prolongation of QT interval. So once you go through this slide, these are the causes of hypocalcemia. So important thing, most commonly, these are the vitamin deficiency or impaired vitamin D action. These are the nutritional vitamin D deficiency. These are the important causes of hypocalcemia. So these are all the rare causes like DiGeorge syndrome, surgical radiation. So one thing what we have to remember is nutritional deficiency and deficiency of vitamin. These are the two most common causes of hypocalcemia. The other things are rare. So management, once we have to do investigation, that is normal profile, complete blood picture, serum electrolyte, serum calcium, phosphorus, magnesium, ALP, vitamin D, albumin. So management part, the approach to treatment depends on severity of hypocalcemia. Mostly the mild and chronic cases doesn't require any treatment, they just require oral supplementation of calcium. The acute hypocalcemic state, we have to supplement IV calcium, that is we give 90 milligrams, that is 1 ampule calcium gluconate contains 90 milligrams. This 1 ampule we will dilute in 50 ml of dextrose or 50 ml of normal saline, and we'll give it IV over 5 minutes. So after giving 1 ampule of calcium gluconate, that is 90 milligrams in 100 ml NS or 50 ml of dextrose, the symptoms should resolve. Once if the hypercalcemia persists, what we'll do is we'll add 10 ampules of calcium gluconate, that is 900 milligrams in 1 liter of normal saline over 24 hours. So after giving 1 ampule of calcium gluconate IV over 5 minutes, we have to see if the symptoms of hypocalcemia persist. We can give 10 ampules of calcium gluconate in 1 liter NS over 24 hours. The other thing is chronic hypocalcemia or hypothyroidism, we have to supplement by giving calcium and vitamin D supplements. So calcium supplements we can give 100,000 to 500 milligrams per day. So basically in our clinical practice we give 500 milligrams of calcium and ask the patient to take oral calcium rich diet. Other thing is giving vitamin D supplements, that is 25,000 to 1 lakh international units daily. So hypercalcemia, it is a medical emergency basically. So mild hypercalcemia is asymptomatic. So and usually hypercalcemia will cause neuropsychiatric symptoms including uh, poor concentration, personality changes, or depression. It will cause polyuria, polydipsia, anorexia, constipation, peptic ulcer disease, pancreatitis, nephrolithiasis. So pancreatitis is one of the dreaded complication of hypercalcemia. So one of the these are the common causes of hypercalcemia. So one is parathyroid related malignancies like multiple myeloma, breast and lung. This is due to the release of parathyroid related peptide by malignant tumors. This parathyroid hormone related peptide will cause increased bone resorption, hypercalcemia. This is calcitriol mediated, that is granulomatous disease like sarcoid, lymphoma. They all cause increased vitamin D secretions. It will cause increased hypercalcemia. This is a blood investigation which we do. So we have to do parathyroid levels, serum calcium, parathyroid hormone related peptides. The parathyroid hormone related peptide levels are seen elevated basically in malignancies like breast, lung, lymphomas. Sorry, in lymphomas there will be increased vitamin D levels. So serum vitamin D levels we should also check, which is seen in various conditions. So hypercalcemia mild is usually asymptomatic. So hypercalcemia, it causes polyuria and increased dehydration. So it is a medical emergency. So hypercalcemia causes severe dehydration. That is, we give 4 to 6 liters of NS over first 24 hours. So when there is increased mobilization of calcium from the bone, that is in case of excess parathyroid hormone secretion. That is either it may be ectopic or normal or excess secretion of parathyroid hormone related peptide. In this case, there will be increased bone resorption because of osteoclastic activity. In this case, we give bisphosphonate, that is zoledronic acid, pamidronic acid, etidronic acid. It will increase. Basically it will decrease the osteoclastic activity of the bone. In some rare instances, dialysis may be required. In patients with calcitriol mediated hypercalcemia, glucocorticoids are preferred. So excess vitamin D related hypercalcemia, we give glucocorticoids, that is hydrocortisone, oral prednisolone. Yes, that's it. Thank you, guys.